In this video, I'd like to discuss hip replacement surgery. So let's first look at what hip arthritis is. So this is a normal appearing hip. You have the ball, you have the socket, there's still space between. That's a normal appearing hip. That's what it's supposed to look like, all right? We've got the pelvis over on this side. We've got the femur coming down here. Now the hip joint is not a bone. The hip joint is made up of where the femur connects to the pelvis. So the acetabulum is that cup, and the femoral head is the ball that sits in the cup like that. When we do a hip replacement, we're typically doing it for something like this, for arthritis, where all of the space is gone. You can see a little cyst right there. You can see what we call sclerosis, which is that white appearance of the bone. And you can see bone spurs off the edges. That's an arthritic hip. And so when we have this and patients have pain, we do a hip replacement. And that entails putting a new socket into the acetabulum with a little plastic liner in it. So there's a metal piece and there's a plastic piece. And on the femur, there's a stem that goes down into the femur with a ball that fits onto the stem. And that stem goes up into the cup component. It looks like there's a space between the cup and the ball, and that's because there's a piece of plastic in there that does not show up on x-ray. So our components, this is the cup component. This is a picture of a real one. And so on the outside, it's coated with this rough surface. On the inside, it's nice and smooth because the inside allows us to insert the liner, and we typically are using a plastic liner. So this outer rough coating, it's this substance that is designed to allow bone to grow onto it. So it kind of wedges in there, and then over time, bone grows onto it. And as it does, it becomes a part of you. It's also got this locking design of the ring that allows for the liner to lock in place so it never comes dislodged. Let's look at the femur here. So this is the femoral stem that I use. It's got the neck, and this is where the ball goes onto it. There's different size balls, but this stem also comes in different sizes, goes all the way from a 0 up to a 10, and it comes in different neck sizes. So if you have, different anatomy, we can account for that with the different options. It's also coated with a substance similar to the cup, a rough substance on the outside that allows for bone to grow onto it. And then that in turn is also covered with what we call hydroxyapatite, which is a substance that even further promotes bone to grow onto it. And it's coated all the way from the top all the way to the very tip of the stem. So it's what we call a fully porous coated stem. And this type of stem has the best data on it in terms of long-term survivorship of any implant on the market. So this is why I like this type of stem. So let's go over the surgery. So, surgical approach, everyone has their own opinion. I'm a firm believer that an anterior approach for a primary hip replacement is the best. It's what most people are wanting nowadays because most people have started hearing about the improved results, the quicker rehab, less pain, lower dislocation rate. There's a lot of benefits to an anterior hip. We basically split through your muscles. We don't have to cut any. We don't have to detach any ligaments, and we can get down to the hip. And so to orient you, that's the head up here. This is the femur going down here, and we take a saw and we cut the head off. And once we remove the head, we can start doing our bony work. So the first thing we do is the acetabulum, the cup part. So we have this circular reamer here. So we can measure the size of the cup or the ball, and then the reamers come in 1 millimeter increments. And we just go up just enough so that we create a hole for our cup. So the cup then, once we've created our hole, the cup then gets inserted. So the reamers, although they come in 1 millimeter increments, we tend to use the odd reamers. And the reason is, if we use a 51 reamer, we're going to insert a 52 cup. The cups only come in even sizes. So we use a odd reamer, 1 millimeter smaller than the cup, and then when we put the cup in, it really wedges in. Now you can see the cup, it has those little holes in it right here. And that's because if that wedge in doesn't give us great initial fixation, we can supplement it with a few screws. And so sometimes we'll do that, sometimes we won't. It just depends on what kind of fixation that cup has initially. If it really gets a good grip, studies have shown that adding screws really don't give you any benefit. But if you need them, they're there for us. The next thing, once we have our cup in, is to put our liner in. So the plastic piece snaps in, we impact it in, and now at that point, the cup component is done. Then we move on to the femur. So once we expose the femur, we've got our cut here where we cut the head off, we can start preparing it. So this is called a box osteotome, and this basically opens up the canal so that we can start preparing. So we mallet this down, it takes out a little bit of bone and allows us access to the femur. Then we start using the broaches. So this is a trial broach, and it fits in through the hole where we use that cookie cutter osteotome, that box osteotome. The broach, we mallet down, we hit it down with a hammer, and it goes further in, and eventually we want it to be pretty much flush to that surface. And again, there's different size broaches. The broach size matches the size of the real implant. So once we get it all the way in, then we'll trial the necks. And so the neck on the real implant is attached, but the neck on the trials is not, because there's different size necks and we want to know which one's going to be best for your anatomy. So we trial typically the first time with a standard neck, but then if we need to tinker with that and change it, we can. And the last thing we put on is this trial ball. So this ball also has modularity. It comes in different lengths, and as you change the length, it changes where it sits on the neck. It can add a little bit of leg length to you so we can dial everything in perfectly for your anatomy. The next thing to look at is how we attach the stem into the bone. As we discussed, this implant is coated with a substance to allow bone to grow onto it. But sometimes people have really soft bone. And when you have soft bone, we'll actually cement the implant in. And the implant can be cemented, or it can be what we call press fit or cementless, depending on your anatomy and the quality of the bone. And we just kind of do what we think's best for you at the time of surgery. So once we've got the final implant in, we put the final ball in, we reduce the hip, and we end up back with this, with a full hip replacement. All right, so let's continue on with our understanding of hip replacement by looking at the x-rays that we get during surgery. So these x-rays may look a little funny to you because they're what we call a C-arm x-ray. So during the anterior hip, we bring in a portable x-ray device, and we can actually monitor the progress of the surgery using this x-ray. It's not quite as powerful as a standard x-ray like you might get in a hospital or even in our office for our preoperative and postoperative x-rays. But it does a great job of getting us intraoperative images so that we can see what we're doing and make sure that the implants are going in the proper position. So this is an x-ray. We've already made our dissection. We've removed the femoral head, and now I have the reamer in the acetabulum. And so these reamers, as we discussed, come in different sizes. So I'm not thrilled with the position of this reamer. We've got a little bit of gapping up here where the reamer is a little undersized, and in addition, it's not medialized enough quite yet. But that's why we check, because we want to make sure we don't take out too much bone to begin with. So I'm not thrilled with this one, so I'm going to increase the reamer size and go in a little bit further. And that's what I do here. And so now it fills up the acetabulum, or the cup, very well, and we're medialized exactly where I want to be. So that reamer is sitting basically where I'm going to want to put the real cup. So we take the reamer out, and then we put the cup component in. So this is the cup component. Now it's screwed onto this inserter device, and we're trying to get it in. So you can see right now, it's not all the way in. It's not sitting as far as the reamer was. So we're malleting this in. We got to make sure that no soft tissue or bone debris gets on the backside and gets in the way. And if you don't bring x-ray in, you can't guarantee that it's fully seated. So I really like being able to have these x-rays. So once we get it fully seated, we get an x-ray here that shows the cup's all the way in. Then we're checking the cup position, because we want to make sure it's not too what we call vertical or straight up and down, and it's not too horizontal or flat. We want it somewhere around 40, 45, 40, 45 degrees of inclination from a horizontal line. So that x-ray looks really good. That's where I want the cup to be. So once we have the cup in, we move on to the femur. And we prepare the femur, we get in the canal, we start putting broaches in, and then we can trial reduce it or bring the ball back into the cup and take another x-ray. And that's what we have here. So the ball is sitting right in the center of the cup. That looks good. The neck's where it's supposed to be. The stem is where it's supposed to be. But if you look, this stem is too small. It does not fill the size of the femur. And so when we're doing the surgery, we don't want to hit it too hard. We don't want to break the femur. So if we think, hey, we're hitting it pretty hard, we can always check it, make sure and say, all right, we're a little undersized here. This stem is not perfect. We're going to need to go up. The other thing we do when we trial is we check your leg length, because that's a big thing. You don't want to end up with a leg longer or shorter after this surgery. So we draw a line. We draw a line on the bottom of the pelvis right here, and right here. So it needs to hit those 2 points right here. And then we see where it intersects the femur on both sides. This bump right here you see on both sides, that's called the lesser trochanter. And that's what we use as the lighthouse of the hip to measure our leg length. So essentially, when we draw this line across, we want to see where that line intersects the lesser trochanter profile on both sides. And that's pretty doggone close. I mean, that's within a millimeter of each other. That looks great. So I'm really happy with the leg length. So I want my implant to sit right here. We just need to get it bigger. And so we dislocate the hip, we take that trial out, we put bigger trials in, we keep broaching to get it to a bigger size to fill the canal, and we end up with an x-ray like this, where the component fills the canal. This patient's bone was not very good, so what I did is cement this, so that's why you see that shadowing down here and along the sides. That's the cement that we use to fixate this stem so that they would have less risk of complications such as fracture. So that is a intraoperative final x-ray. Before we close it up, we get an x-ray to make sure everything looks perfect. And this hip looks perfect. And that's what we're going for every time on a hip replacement.